All right, good morning everyone, and welcome to today's webinar, Improving the Patient Experience in Virginia's Hospitals, the 2018 Senior Leadership Exercise number 1. So before we get started, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You're listening in using your computer's audio system by default. If you'd prefer to join over the phone, just select the telephone option in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address them during the Q&A session at the end of today's webinar. The purpose of today's webinar is to provide an overview of the senior leader exercise we are pushing out to Virginia hospital CEOs, executives, and patient experience staff. So in addition to the patient experience leaders and service excellence leaders we typically have on these webinars, we also have several CEOs and executive leaders from hospitals listening in as well. This recording the recording of the webinar is also going to be shared with all state hospital CEOs. I'm going to start by providing a brief overview of the exercise. A more detailed summary can be found in the meeting invite as well as in the handout section of the webinar platform. We're going to review both the benefits and considerations in completing the exercise and how it can improve patient experience as well as the quality and patient safety within your facility. And then we're going to hear from Sentara Martha Jefferson Hospital on how they completed an exercise similar to this and the impact it is having on their patient care. Our speakers today will be Carrie Brady, VHHA Patient Experience Consultant, and Jonathan Davis, President and CEO of Sentara Martha Jefferson. Mr. Davis was kind enough to move his schedule around so he could be here with us today and discuss his experience in doing this type of exercise with his staff and to talk about the excellent culture he's created that allows his staff to feel comfortable discussing opportunities to improve with their senior leaders. We're hoping to leave a good chunk of time at the end for questions, so this is really your time to ask both a CEO and a patient experience expert questions on how to go about doing something like this, as well as their experience in doing so. I want to provide just a little bit of background as to why this exercise was developed in the first place. So, as you all know, the Hospital Association has a 2020 target of moving the state's top box overall rating on the HCAHPS survey from 70% to 75%. This past year, our patient experience efforts have really been focused on 3 different areas. So the first was establishing a foundation for the program and a structure to the shared learning. That involved targeting 4 main areas: leadership, staff engagement, patient-family engagement, and effective data use. The second area was content creation dissemination. So you all should now have the Patient-Family Experience Improvement Guide. That was a toolkit that involved staff and leadership engagement strategies as well as individual domain best practices in the HCAHPS survey. The second big deliverable we released was the HCAHPS data dashboard that allows hospitals to identify peers that are excelling in certain HCAHPS areas, certain domains. That has led to a lot of increased collaboration throughout the state, using the association as a liaison to facilitate those conversations. Both those items are on our website now, so I encourage you guys to go on there and utilize them as resources as you try to improve care. The third area was really building a network of hospital peers and collaboration throughout the state, so really nailing down who should be involved from each of the facilities. We really want you all to feel comfortable reaching out to one another because so far, each of our members have been more than willing to share their experiences, and it's been really helpful in having discussions on how they overcame hurdles that you may be experiencing in your facility. So for 2018, our Patient Experience Forum, the board that guides me in these efforts, identified the need for their hospital leadership to be more consistently and visibly engaged with staff in the patient experience efforts. In response to this need, we had each member of the VHHA Board of Directors commit to 3 very broad engagement strategies that help enhance patient experience. Those were partnering with patients and families as advisors, something we're going to continue to work on helping launch in all of our hospitals in 2018. Second was enhancing leadership engagement with staff. And the third was seeking collaborative opportunities with hospitals across the state. So the signatures to these commitments, this was leading up to the VHHA Fall Conference, which had a service excellence theme, as well as Patient Experience Week last year, where we were pushing out best practices for each of these commitments and recognizing hospital CEOs that were excelling in each of those areas. So this year, we wanted to further demonstrate those commitments in an effort to help senior leaders get a fresh perspective and improve our state scores. So this brings us to the senior leader exercise number 1. I say number 1 because we are planning to do a number 2 later this year. And the exercise goes, so the VHHA, with support of the board of directors, is asking every Virginia hospital CEO and the senior leaders of their choice to identify staff that were recently patients or have had family members who were recently patients and invite them to participate in a group discussion about their experience. And that can be over coffee, breakfast, whatever fits your facility best. But the purpose of the conversation is to have meaningful dialogue with your employees on both the successes in their care as well as the opportunities for improvement. So again, if you want to read all of the details of the exercise, please reference the one-pager that's in the handout section of the webinar platform. All right, so I'm going to pass this off to Carrie Brady, VHHA Patient Experience Consultant, who's going to review this in more detail and talk through the benefits and implications of the exercise. Carrie?
Thanks, Mike. So we wanted to talk a little bit about what our objectives were and what the benefits are of this exercise. So really, as Mike mentioned, there are these 4 foundations for all of your patient experience work: leadership, staff engagement, patient and family partnership, and effective data use. And this particular activity that we're asking all of you to engage in targets very closely 3 of these foundations. So we are doing this because you can maximize the value of this effort using a minimal amount of time, and you're using existing resources because there's lots of things that you could be asked to do, but we also know that hospitals are already overloaded, and what we are very passionate about is finding out how you can use your existing resources more effectively to have a greater impact, because just adding more to your to-do list is not going to be effective. So this is a simple and powerful way that you can show your leadership in this area, you can engage your staff, and you're getting a perspective from patients and families who have experienced your care there. The value of using staff discussions cannot be underestimated, but it often is. Think about this. So many times, staff members are using your hospital, or they have their loved ones using your hospital. Now, that's a good sign because you want them to be using your hospital and to feel confident enough in that care that that's where they bring their loved ones. But then, when something goes wrong with that experience, or even when something goes right, if all they get is their usual HCAP survey or whatever your regular process is for finding out what an experience of care was like, it's a missed opportunity. It's almost as if the organization is sticking their head in the sand, as in this picture, and not tapping into some of the best information and the easiest information that you can get about patient experience in your organization. Because after all, the people that work there are invested in the success of the organization. And when they're bringing their loved ones there, they want them to have a good experience. And they're insiders, so they have a unique perspective. This does not replace you using patient and family advisors, because it's really important that you get both perspectives from your patients and families who have nothing to do with the hospital otherwise, and from your staff. Your staff have the ability to not only comment on what the experience was like, some of them are familiar enough, if they're clinical staff, with what the process is supposed to be, that they can help you diagnose where the breakdown's happening, because they are able to see it in a different way than someone who's not familiar with the processes. So they have incredible knowledge that they can share with you. But if they're never being asked, if there's not an opportunity, then you don't get that knowledge. You also then are sending a very strange message to your staff about the value of their experiences and whether this is important. So by engaging them directly, you're aligning their incentives, you're enhancing the impact, because these people really care. Some organizations have taken this exercise so far that they have built entire initiatives and redesign platforms around what their staff talked about as their experiences with patients. And that's what they've used as a major part of their redesign in their processes, because when their staff got engaged and said, well, yeah, here's what happens to us, and this is not how we want it to be, here's what we ideally would like, then they were motivated and engaged and they moved forward. So there's a lot that you can do there to engage your staff. We also know that the patient and staff experience are related. Many Virginia hospitals, as in other states, use AHRQ's survey on patient safety culture as a routine part of patient safety efforts. And you're also, of course, using HCAHPS. Well, both those surveys are asking questions that relate to teamwork, leadership, communication, transition, staffing. These sorts of things affect both surveys. And there's an interesting thing. This is a study that was done looking at the correlation between these surveys. What they found was that the strongest correlation was organizational learning and continuous improvement. Mike, can you advance that slide? Because for whatever reason, it's not advancing. There's lots of things that are correlated, but that organizational learning and continuous improvement is the strongest correlation. So that means you're learning on an ongoing basis, not only from what's working well, but from what's not working well. And that's what these conversations with your staff can do for you. Next slide, please, Mike. So we have some suggested guidelines for you in setting up this conversation, because it's a little different than what you would do typically with your patients and families who aren't involved with the hospital. So we suggest that you have this conversation over some kind of meal. It just makes it a little less formal, can get people more comfortable. That's also good to do with your patient and family advisors. But the next two things are really important about creating a safe environment and assuring people that their identities will be kept confidential. Because what's different about talking to your staff is that they may be speaking about things that they know are going to reflect poorly on their peers. They know that, they may feel a little awkward about, well, I don't want to share this experience. So you want to assure them that this is a safe environment, that you want them to be candid, that their identities will be kept confidential. And also you want to make it clear that this is not about singling out particular staff members. So you're not asking them to say, so-and-so did X. You're asking them to talk about what their experience was like, but you don't want to put them in an uncomfortable position. Sometimes they may volunteer something specific, but you are respecting whatever kind of boundaries they're setting and making it safe. You also want to make sure that someone is taking notes on this conversation, because it's very important that the conversation have follow-up, and I'm going to talk more about that in a minute. But you don't want to gather all of this great information and then end up not being able to do anything with it because it wasn't captured in the moment. And sometimes if you are able to have someone actually taking notes, not just on the concepts that are being discussed, but some of the words, it's sometimes good if they're just kind of typing, almost like they're transcribing. You wouldn't, of course, bring a transcriptionist in because that would make it too formal, but just capturing that, because those words are very, very powerful. And the way that people express things can help you when you're motivating people to make changes. So consider that having someone take notes, or even just be, typing as fast as they can, the conversation. Next slide, please, Mike. You want to start by having them share their top of mind impressions. This is really important because if you started with substantive questions, they will answer your questions, but you're already at that point steering the dialogue. And as soon as you start asking substantive questions, they're going to start narrowing their focus to the topics of what you're asking. So you want to start with what was their top of mind impression about their experience, whether it's positive or negative. What was particularly positive and strong about their experience and stuck out for them as something that was fantastic, and what would they see as the biggest opportunity for improvement. So now you've kind of surfaced all of those top of mind issues for the staff members who are participating. You also want to invite them, if they've had experiences at other hospitals, either as a patient themselves or their loved ones have been to other hospitals, tell them that they are welcome. You welcome them to share those experiences as well as a comparison. So you don't want to just talk in general about experiences at other hospitals, but if you're saying like your experience here compared to what your experience was at another hospital is really relevant, because it surfaces, again, not only what you're doing well, but where your opportunities for improvement are. So encourage them to do that, because sometimes people are reluctant to mention experiences at other hospitals if you haven't specifically invited them to do so, but those comparisons can be helpful. Next slide, please. you also want to ask them about whatever domains are very important to you, whatever your priorities are for improvement, then you want to inquire about those. But you want to wait until you've surfaced the broader issues first. So for many hospitals, it's communication, it's how are we educating our patients, responsiveness, transitions, whatever your particular hot button issues are. Could be cleanliness, could be quiet at night, whatever it may be. You want to ask them some questions about that to get them engaged in that discussion. And when you don't want to have too many questions either, because this isn't going to go on for hours. So just have some targeted, prioritized questions that are relevant to your organization specifically. And then at the end, you want to make sure that you ask if there are any other issues that they've observed that they want to bring to your attention, including quality and safety issues, because you don't want to miss this opportunity with your staff members in the room to identify other things that are happening that may not be specifically patient experience concerns, but maybe some things that they observed or are concerned about. So you want to ask them about that. I have found in doing focus groups around the country with hundreds of hospitals that in that last 5 minutes, that's when sometimes the most valuable information comes out, because that's that burning issue that you didn't specifically ask about because you don't know it's there. It'll come out in the last 5 minutes if you ask, is there anything else you wish I had asked about? Is there another issue that you came here today wanting to talk about? So pay particular attention to that, and also allocate a few minutes after that meeting, because what also tends to happen is there may be some people on your staff who are reluctant to speak up in the group, but there's something they came and they wanted to share, and they will grab you right as the meeting ends and say, there is one other thing, I'm sorry we ran out of time, but really they just weren't comfortable speaking up, and they will tell you what it is that's on their mind. So be sure that you're not rushing right into your next meeting. Leave at least 15 minutes so that if that does happen, you have the opportunity to get that information, because it's important and can be really valuable for you to have it. Next slide, please, Mike. Listen for innovation. If you are asking staff when they identify an opportunity, do they have suggestions for how this could be addressed? Do they know what is the challenge in the existing process that may have prevented it from working as well as they wanted to? Or what changes would make it easier for staff to be able to do whatever is the, quote, right thing for patients? What is it that, what are the barriers, what are the challenges that are getting in the way? If they know, it may be that they don't know if they're not familiar with that particular unit or department, but give them the opportunity if they have a suggestion for improvement to identify it and not just to identify the problem. And one of the reasons why you do want to ask them about the best part of their experience is often there's incredible innovation there that you can replicate throughout the organization. So a quick example that I wanted to share with you is I was doing a presentation for about 30 hospitals through a state hospital association initiative, and we were talking about talking to your staff and engaging them. And this one nurse raised her hand and shared an experience that the hospital ended up replicating throughout the hospital. They invented what they were calling reverse teach back. And what happened is this nurse, who had learned teach back, used it with her patients, and teach back is, for those of you who may not be familiar, is when you are communicating information to a patient, and after you've been having this dialogue with them, you are asking them to teach it back to you, the purpose being to verify that they understood what you shared and making sure that that communication has actually occurred comprehensively and consistently. So it's a dialogue. Well, what happened in this hospital was they were a teach-back hospital. They were using that regularly for discharge conversations and other things. She came into the hospital with her young child in the emergency department. And of course, you go through triage and you're telling the same story over and over again every time someone else new walks in the room. Well, when the pediatrician or the emergency department, pediatric emergency department physician walked into the room, he said to this nurse, I'm going to tell you what I've heard so far and repeat back to you the story that I've been told. And then I want you to correct anything that I have wrong or fill in any gaps that I'm missing here in the story. And she said it really struck her because he did, share what he had, and then he was teaching back to her what the hospital already knew, what information they were going on, because they're basing, of course, their response to the information that you've provided. So she said that just really struck her as something they should be doing all the time, that sharing with patients and repeating back to them, here's what I hear you saying, here's the information, gives the patient the opportunity to connect those dots and to fill in some gaps just like we do in hospitals when we're using teachback with patients. So the hospital ended up adopting reverse teachback throughout the hospital. There were several other hospitals in attendance who said they were going to go back and do the same thing. And that was just because it was a staff member who observed something interesting happening in the care of her child that she brought to the hospital's attention. And there are lots of other examples where innovation has come out of these kinds of discussions because, again, your staff members have the desire to improve, and they also have the information that helps them understand the processes, because an ordinary patient coming in who has no healthcare experience doesn't know what teachback is. But a nurse who's been trained in teachback can see this and see what reverse teachback could be. So it's useful information. So I look forward to hearing about the innovations that come out of these meetings that you're going to have. Next slide, please, Mike. After the meeting, it's very important. What you do after the meeting is as important as what you're doing in the meeting. And this is where things sometimes fall apart, because people do meetings and the meetings go well and everyone's excited about the improvement opportunities, and then everyone goes back to the pile of things that they have to do and it just sort of falls to the bottom. When you've invited people and just begun sort of opening up this dialogue, it's really important that you show the people who attended, as well as other people who may have chosen not to attend this first time, that meaningful change happens out of these meetings. So you want to document the findings. You want to distribute these to improvement leaders in the organization, again, confidentially. You may find that some of your staff members volunteer to be identified. And you may ask some of them if there's a very specific thing that needs to be looked into. Often people are willing to be identifiable and say, yes, I really want to address this, and let's, dig into the experience more tangibly. So that's possible. But for people who wanted to remain anonymous, you need to respect that. Follow up with the participants and let them know what you're doing with the information that's shared. You're going to say that in the meeting anyway. You're going to say, something along the lines of thanking them for participating, that they've given you great information, and that it will be used for improvement. But a little bit later, a few days later, a week later, you want to circle back around with them and let them know that, this is the information, it's being distributed. Invite them if they want to volunteer to get involved in improvement efforts. And then you want to create a mechanism for staff to share on an ongoing basis. And you want to give some thought to what that mechanism is going to be. That's obviously entirely up to each hospital, but you don't really want this to be a one and done kind of experience, because you will have built great momentum, made these connections, gotten this information, and you're going to see the incredible value in it. So, Mike, if you can go to the next slide. We want you to think about how you're going to build on that momentum, and going into the meeting, be thinking about, what could our next steps be? So this is some of the ways that different organizations build on this momentum and really incorporate your staff experiences as patients and family members into everything you're doing on an ongoing basis. So it just becomes part of doing business on a routine basis. You can do this in staff meetings, where you ask staff as part of the staff meeting, does anyone have a recent experience that they can share that's, relevant to improvement or whatever it is you're talking about that day? Certainly leadership retreats present opportunities. If you're bringing your management together, involve patients and families in that as well who are not staff members. That's just something else you can do that's very effective. But also engaging your staff. I've seen this done in a wide-ranging management retreat covering a lot of different topics, but they had a few different staff members who had had patient experiences stand up and talk about it. And what was really powerful about that was, because they were insiders, their colleagues really focused on what happened and related to it as, wow, this happened to one of our own. This is really an opportunity. And the dialogue, they had small table dialogue after that, where people were really kind of working on different issues. It was powerful, and people were very focused because they empathized with and related to their peers who were bringing this to their attention. So it's a powerful way to use this information in those management type retreat settings. Also, you can feed this information, and should feed this information, back to your patient and family advisory council. If you have a council in place, or you're using patient and family advisors in other ways, it's very helpful to kind of bounce ideas back and forth between the groups. Obviously, your staff is getting information from your patient and family advisors, but it's interesting to feed back to your patient and family advisors some of the experiences of staff and let them add on to that what their own experiences have been. So you can have a two-way street there. And then what's really exciting, and what we're going to hear about from Jonathan Davis now, is doing this on an ongoing basis with senior leader rounding on staff. When Mike and I were looking for a peer to feature on this call, because we always like to have a Virginia peer to talk about the experience, we were delighted to find out that Sentara was already doing this, and not really surprised that they've already taken it basically as far as this can go in terms of ongoing senior leader rounding, asking staff about their experiences, because that's powerful, and it's powerful in so many different ways. It sends a message to your staff about the importance. You have that ongoing dialogue. You're able to use this for improvement. And so it addresses all your foundations and really creates incredible results, because Sentara is a leader in Virginia. I know that they're doing lots of different things. We can't credit all of it to this particular initiative, but this is certainly part of what's built that culture and sustained it in the organization and contributing to their success. So we're really delighted to have Jonathan Davis and Catherine Hughes here with us today, who are willing to share their experiences. And then following that, we will, as Mike said, we've left a substantial amount of time for questions and discussion, because since we are asking you to take the challenge and go out and do this, we wanted to make sure that there's an opportunity to ask any questions you might have about how to get that done. So now I'm going to turn it over to Jonathan Davis. Thank you.
Very good. Thank you, Carrie. Thank you, Carrie and Mike. I appreciate the time and the opportunity to just share with everyone really our experience and the things that we are doing at Sentara Martha Jefferson Hospital. And first, maybe as a little bit of a background, here is the size and scope of Sentara. We are a collective group of community hospitals serving our communities, but this is what we look like in aggregate. And our 12 hospitals, 12 long-term care assisted livings, and we have really kind of one medical group, but it's in 4 regions of the state of Virginia. And then we have a health insurance plan, and you can see kind of just our overall size and our employee base at 27,000. These are the regions I mentioned earlier. So this is kind of our footprint in the state of Virginia and North Carolina. And specifically for Sentara Martha Jefferson, we've been in our community for about 111, going on 112 years. And, we were started with a number of physicians who opened our organization and started our organization. We opened our new hospital, moved from downtown to kind of the periphery of the community, or the city of Charlottesville. And we have, this is our new campus that you can see. We're 176 private beds. We run a census ranging anywhere from 110, 120 to 150. And so that's kind of our range of census. In building our hospital, we have a pretty robust foundation. I think last year, the foundation here in our community raised about $3.5 million for community dollars, and we raised $50 million for a capital campaign to build our hospital, which opened in the end of 2011, beginning of 2012. So, I think first and foremost, I've been in healthcare for a little over 20 years, and had the opportunity to be part of Sentara 3 years ago. And the thing that sits true with me, and probably with most executive leaders, are my core values. And I teach this, and even in our orientation, I talk about your core values as an employee, and what is your mission as an employee, and how does that fit with our mission to improve health every day as part of Sentara. And we talk about these commitments, and I'll describe these in 2 ways. I think first is the general commitment of being our best for our patients, keeping our patients safe, respecting our patients, treating with compassion, responding to their needs, informing them, etc. But I would also say, a key word in each of these commitments is always, and that really leans on the function of reliability. We don't do it just Monday, Tuesday, Wednesday, or we don't do it when we're happy and feel good at work. We do it all the time. We're 24, like every hospital, we're open 24 hours a day, 7 days a week. Probably most of our patients that would come to OB are fairly happy and great to be here, and they're going to have a child, and it's a new day in their life. And for others, they're not really looking forward to showing up to our ER, or they are coming to, have a diagnosis of taking their annual mammography, or taking, their primary care physician found something, they're coming to us, and they have a tremendous amount of anxiety. And so, the way I talk to our team is we really owe our guests the opportunity to take that burden away from them and not burden them with, our trials and tribulations of our day. And so, as a product of that, we lean on all the people in our community. So this is just a representation of, our board members, our volunteers, our physicians, and employees. And, our outcomes are really only as good as the collective team. And, to me, that is certainly attributed to a function of rounding, which I'll talk about here in the next slide. So why round? 20 years ago, I started inpatient care. So probably it's a product of who I am and what I believe in, as I said earlier, really a product of my professional core values. And, I believe, as I said earlier, most of our patients or guests will come here, and we really need to understand what their needs are. And so being actively engaged with our patients, as Carrie said, there's no better opportunity to understand continuous improvement than being available to listen and learn and inspect the work we do in taking care of our patients. And it gives me the opportunity to visit with patients, visit with guests, but also, really open my eyes up to the environment. And so you can walk down the hall, you can look at the baseboards, you can look at the marks on the walls, whether we need a fresh coat of paint. You can walk into a patient's room and, assess, is it tidy? And tidiness to me is a function of quality. If I walk into a room and it's not tidy, we've not tidied the room, what does the patient, what do the guests see as a function of what we're delivering to them? And so, it's really those small details and attention to detail that we've got to have in taking care of our patients. But when you look at rounding, I really focus it, and I use these two words fairly routine here. I say, is it a purposeful round, or is it wandering? And wandering to me is real no agenda. It's just being out on the floor and just some random element of rounding. And I think Carrie said it well, around getting feedback from employees, taking notes. I mean, you're addressing it in a very organized fashion. So when I look at my rounding, and certainly this is just the way I do it, there are others, I'm sure, that have their kind of agenda that works very well. But for me, it really is a focus of being purposeful, rounding on staff, rounding on patients with staff. And in this slide, it's not so much asking for problems. It's a very negative tone. It really is what is working well. And so let's highlight what's working well. Let's understand what we need to reinforce and continue to do really, really well. And let's focus that on safety, customer service, equipment related. Let's really understand that environment and how we are helping our staff be successful. And then the next question, and I would say it's very similar to what Carrie said, opportunities for improvement. Well, to me, it is, you'll hear people say, look for problems impacting our operation, so it's a kind of a negative. And I like to say, what are your barriers to being successful? And I ask that question because I truly believe every person and every team member has a different role. EVS has a different role than the nurse, than the patient care safety partner, than the sitter, maybe even for the patient. And so, each of those individuals, what does success look like for them? And I'm interested in that. I want to understand, what does that look like? I take notes. I typically have a 1 or 2 follow-up item that I bring back to the office. As Carrie mentioned, write it down, follow up, and really learn. And it's interesting because, there are elements of inefficiencies, barriers. We always find a way around those barriers. Those workarounds are typically longer, less efficient, pretty frustrating, especially to very good team members. As you look at retention of your staff, you do not want to frustrate the most talented people by having them do the most inefficient process. So, but within that rounding, seek opportunities not to catch. We think of that as a negative, but to recognize our staff are doing something right, give them feedback, coaching, know why and what we're rounding on. So, for example, we have safety huddle every day. We take topics out of our safety huddle. That is a product of our daily rounds. We have topics within the month. We call it rounding to influence that we round on. So it may be, hand washing. It could be even central line placement. It could be call light responsiveness, tidiness, as I mentioned earlier. And we share those specific topics, and all senior leaders round on those specific topics across the organization. We're all assigned an area we're responsible for. We rotate areas and rotate topics on a monthly basis. So it's very well constructed, it's very well organized, and it's a centralized function that we all participate in. Connect employees, find opportunities to coach, thank them for their daily efforts, and manage up with patients. I believe that you have to use key words, key times, and so being able to walk into a patient's room and say something great about the nurse that's taking care of them, that's worked here for 20 years, is meaningful to the patient and meaningful to the family. And so, there's just a different level of engagement when you have effective rounding. It's important. I think beyond this, most of the topic as we talk about it today is around employee engagement and employee stories. And, I do believe that, our staff and our team members really understand the inner workings of our organization and probably have some of the highest expectations around how they're treated, their loved ones are treated. So here's a story that, I'll share with you. I thought this was a great opportunity for us to learn. We're all about transparency. And so I think Carrie mentioned earlier this element of safety and having a safe environment is absolutely crucial. It's not about who's told on who. It's about what we learned and how do we follow up on that learning and how do we improve patient care from that learning. So this is just one example of that. It focused on aspects of her care that were certainly good, registration, but the post-surgery nursing care experience overall was not good. And what she provided, the examples was the transporter was an example of that. Another nurse came in and commented that it was the first time they had taken care of a patient with her type of surgical procedure. I mean, that'll kind of make you wince. And so, so with that, we have ongoing education. You can see our actions. We have a culture of always education session. And then we have a committee that really kind of functions to oversee the education component. And she came and actually presented to this committee. And we were able to thank her, for her willingness to come share her experience, be candid with us. I do, I think Carrie mentioned this, I do, some staff will come to me and I have the opportunity for them to tell me a story. And some people want me, to share their story openly, like in this example, and others don't. And, we have to certainly be respectful of that. But again, I don't focus on who the message came from as much as what the topic is and where the opportunity is for us to provide better care. And so this was a teachable moment. It really is, as I've said all along in this presentation, let's not burden or frighten our patients, with our problems of the day. Let's treat every patient as if they're a member of our family. How would we want our family members treated? And let's be attentive, and very cognitive about how we connect with our patients. Knowing something personal about them is probably the best way to do that. Last is just some other comments. And, I think this is really the meat of, your measure of success is the positive, recommendations you get. Some, again, key words here: thoughtful and trying to alleviate her discomfort, explain what was happening, and tended to all my needs. There's another one here I feel at the bottom: to create an experience that was warm, comfortable, and compassionate. My mother's feelings and comfort were of utmost concern by every single staff member who cared for her. And then talks about the wonderful care, empathy, and concern. And those are really the key words. That's what we do. We have to manage the business aspects of our operations behind the walls of the organization. But what we do and how we do it front and center really are the product of getting feedback from our employees and our patients, and our ability to act on that feedback. So I hope that was helpful. Again, it's just certainly my perspective and our experience, and I think that it has served us well as a North Star, and I'm happy to take any questions.
All right, thank you, both Carrie and Mr. Davis, for that information. I think it's really helpful to see best practices placed within the context of an organization. Especially see how leadership plays a role in developing, a culture that allows those best practices to really flourish. And kudos to the participants here. We had a lot of questions coming in, so I'm just going to start reading these off and let Carrie and Mr. Davis provide some comments. Get this figure here. Has it been, this can be either Mr. Davis or Carrie, has it been your experience that staff typically receive better care as patients than other patients? And how would you address that notion?
Yeah, in my experience, I'm happy to take that, Carrie. In my experience, they probably do. Not for a just reason, but the reality is, and the lesson we can learn from that is, it's because we know them personally, right? They work here, we know them, we know something about their family, we've known them for 10 years or a long time, so we're connected to them. And the lesson there is, how do we get that level of connection with every patient, not just an employee? And so we teach that in our culture of always. We talk about it all the time. We have the expectation, know one thing personal about the patient. They have a pet. What's the pet's name? We have had some instances where their pet came to visit them because of that conversation. So they probably do, but it's because of that personal connection. And the lesson there is, we have to develop that same personal connection with every patient.
I think that's a great way to answer that question. It is, I think, a reality in most service industries. If you know the people that are giving you service, if you've developed a relationship with them, then of course it's a different experience, because there is a personal connection. And that is part of the reason why talking to your staff when things didn't go particularly well is really powerful, because we expect that was probably a better experience sometimes because of that connection than others would have. So looking at where things are falling down there is very powerful. And in some organizations, to the point, which I think is an excellent one about having that personal connection, there are some organizations that, as part of their hospital admission, so in your regular admission intake, they ask a few questions to personalize that experience. What do you enjoy doing in your free time? What is most important? There are just a few questions that you can ask, and then that becomes part of the medical record. So when staff are coming in, that information is available to them. Some put it on the whiteboard, like football fan, loves the Giants, whatever. They put a tidbit of information on the whiteboard, or in the record, or on the door, or inside the door, but somewhere, so that staff have that connection. It started in pediatrics, from what I understand, was much more widespread because staff wanted to connect with the kids in that way, and then has expanded to be more common in adult settings as well. Because if you have that connection, it does change things on both sides. It changes things for the patients, and it changes things for the staff, because they feel that connection and they feel really good about it as well.
And I would add to that only to say, I think Carrie used the right word. I would say the experience probably differs, but the care and the outcome do not differ.
Absolutely, I agree.
Regardless.
Yeah, the clinical processes, all of that, those need to be neutral too, and just consistent. But that little added touch is the personal touch.
All right, our next question is actually a three-parter. Carrie, I'm going to let you answer this first, because this kind of bridges on what we were discussing before the webinar with the distinction between advisors and staff. Our question is, is this exercise only to be done among the inpatient HCAPS environment? That's the first question. Second question, do you suggest doing this with staff first, or can we go outside and get a friend to come in and speak? I think that's bridging into the advisor category. And then how big of an executive audience do you recommend?
Okay.
And if you want me to read those back, I can. Yeah.
Oh, that's okay. I think I got it. The first question, whether it's only inpatient, no, you can do this for any aspect of care that you are providing. And in fact, inpatient and outpatient, they flow together. If your patients are coming, for example, I did this work recently with a hospital focused on a particular service line, and it turned out that the outpatient experience was driving the inpatient HCAP scores, and the outpatient clinic wasn't even owned by the hospital, but it was in the hospital building. So the patients had every reason to believe that that was part of the hospital, and they had, you know, lots to say about what was going on in that clinic, and so that was affecting what they thought the experience was going to be like when they were coming in as an inpatient. So it's really important actually to look at all of the services that you're providing across the board, and this activity can be done. You don't even need to do them in separate groups. You can just invite all staff in any part of the hospital to come in and talk about it, or you can do it separately depending on your size. You might want to break it up, but it's definitely beneficial to do it across the board. The second question, Mike, that was about bringing in patient and family advisors versus doing this just with staff.
Yeah, she was asking, do you suggest doing this with staff first, or can we go outside and get a friend to come in and speak? And then I just kind of thought of our distinction between why not all of our hospitals have set up advisors yet. That's something we're still going to keep working on in 2018, but why we're actually trying to universally apply this to all hospitals by using staff.
Right. So yes, you can certainly have people, staff members may have friends, neighbors, other people who've had experiences that they want to bring into this. And those people are fantastic to include as advisors. And the reason why they're so fantastic is because somebody who is affiliated with the hospital has now pulled them in, which means they're connected in some way. Some organizations that don't yet have patient and family advisors in place, there's a reluctance about letting people behind the curtain. I mean, other organizations that have the advisors in place can tell you how they got past that and how it's really bringing people behind the curtain to see what really goes on in the hospital. They really suspect a lot of what goes on in the hospital anyway, and so bringing them in strengthens the relationship. There's no reason to be afraid of that, but still in a lot of organizations, there's this just discomfort with, well, if we bring them in and they see what's going on, that's awkward. But if you have staff members that have people they care about, they're involved with in some way, friends that want to come in and share their experience, then that helps you build a group of advisors for the hospital as well, because those people have a story to tell, they're connected. You do need to have a process if you're bringing in advisors, and I know we've done a webinar separate from this, and I don't want to dig way in detail of that, but just to mention, it is really important when you're selecting community advisors, patient and family advisors, that they are able to move past their specific story. They have a story to tell originally, which is usually why they're involved, but you need them to be able to think more broadly and respond to issues that weren't rooted in their personal experience. So that's a consideration, but it's good to do both. And the basic same process that we're suggesting that you follow here with your staff, you can follow with a community meeting of advisors. And I know some hospitals that have done this, that have created advisory councils after putting out a call on Facebook, social media, various, other places, hospital distribution lists, asking people to come in and talk about some changes to a service line and some improvement projects. And when that was going on, they were asked at the end of that first meeting if anyone wanted to volunteer to be part of a new advisory council, and nearly everyone in that meeting agreed to come. And the ones who didn't, it was just too far for them to drive on a regular basis. But otherwise, everybody was engaged at that point, and it was a really nice way to start it. So doing a meeting like this with community members can be a way to dip your toe in the water of creating an advisory council or recruiting advisors. And then the third question was about how many executives to involve, Mike? Was that the question, or how?
Yeah, how big of an executive audience do you recommend? And maybe Mr. Davis can provide some context too. I think it's contingent on the hospital you're asking, but maybe if you would like to provide comments, go ahead. Sure.
Well, it's Jonathan. I think when you I guess I I fall to the, kind of philosophy that's part of our responsibility. We walk in an organization every day that takes care of patients, and we ought to all know what we're doing and how we're doing it and what the outcome is and how we're going to improve. And so I find that the responsibility of everyone. And it can be the manager, it can be the staff member who is making hourly rounds, it can be the manager who visits all patients on their unit, it can be the director who may, sporadically visit some hot areas, it could be, the president or the VP to round in specific areas, but it is the responsibility of everybody. We have all of our executives rounding. We don't all round on the same units every day. We orchestrate it in a way that, it has a collective approach to offer incremental benefit to the organization and to our patients, rather than a scattered kind of approach where everybody just is hurried up, tasking away. So it's got to really produce a product at the end, not be a task on your list each day.
Perfect. And we actually have multiple questions here about rounding. I'm going to try to combine a few. So, Mr. Davis, as an executive, you have a lot on your plate. How do you find the time to do rounding and engaging with staff members? That's the first question. And secondly, what do you recommend as the frequency of purposeful rounding on staff?
So let me start with the later. I think that, your goal ought to be to try to do it weekly to get out of your office. It can only take an hour. An effective round doesn't have to be 2 hours, it doesn't have to be long. It can be even 30 minutes, 45 minutes. I think that, I give you a great example. So I schedule my rounding. That's the best way that it can happen. I block out the time. So it's a commitment that I have. Monday I went and rounded in radiation oncology and medical oncology. It took me 45 minutes. I visited with 2 of the imaging techs that were actually treating 2 patients. So I went to each one of them in the control room and talked to them about what they were doing, asked them questions. They sent me a note, said, thank you for coming to round. It was great. We learned something too. And, I got to talk to them about things going on in the organization, and I got to learn about what they do. On the oncology infusion side, I really got to understand some of the traffic and some of the challenges with infusion patients, non-chemo patients that are getting blood products, and, how do we need to look at serving them better, more efficiently, maybe in a different location. And so, I picked that up quick. It took me 45 minutes, but it is a skill that you'll hone and you have to be efficient with, and and at the same time can't feel rushed by the employee. So you can't dart in and dart out. There is an art to it. I think the question earlier around the advisor, do you have someone come in to teach, or, is that a person who's actually had the experience? I think Carrie said it well. Organizations that are new into this journey would probably be well served from people coming in to say, here's how I do it, here's what it looks like. But overall, I find the most effective way is to schedule that and make it a weekly product of your workflow.
And is there a distinction when you round? Are you typically rounding on your staff? Do you ever round on patients? That's a question that just came in as well.
I round on staff mostly. Then I will, in specific areas where we may have something I'm particularly want to learn or concerned about, then we will go into a patient room together. But it just is it depends on, so I was in the cancer center, I wouldn't go see the patient that's getting the radiation treatment. I would just go talk to the staff. I may have a med-onc unit, though, for an inpatient unit, and I'm interested in, if the patient was admitted from the outpatient center, I may be interested, okay, well, how did that process work? How did the flow go? Did they have to register? Were there delays? And then I'll walk in, but I will go with the nurse. I typically walk in with someone. It'll be the nurse or the manager. And the reason for that is I'm not there to inspect the work of the team. So it's not about not trusting what they do. It's about learning together about how we can do it better.
Perfect.
And that's really important because I've been involved with some facilities who have asked me to go round on patients and ask them some questions. And it is very difficult if you are not going in there with staff to convince a patient that you are doing this in support of the organization, because they naturally then, like you said, are thinking that you're there to inspect the work or that there's an issue, and then the dialogue is not constructive at that point. But if you're going in with your team and saying, hey, we wanted to ask you, like you said, about that process, it sends a very different message. And don't misunderstand, I'm not saying no one should ever round alone on patients. There are ways to do that. But in this particular process, doing it in that way, again, you're engaging your staff, you're showing that you care about their work, and you're together looking for more information to improve it. So that partnership comes across to the patients as well.
All right. And we have a clarifying question. When you bring in staff to speak about their experience, is it recommended that they're coming in to share their experience with a larger executive team, or should it be more of an intimate conversation between just a select few executive leaders? And I think there's a couple different ways to answer that and go about doing this. It's why we wrote it in a way that's much more flexible and can fit your organization. But Carrie or Jonathan, if you have comments, please go ahead.
I think it depends on I think it depends a lot on the culture and the current level of trust in the organization. I think that's organization specific. If you think that you can get, your C-suite leaders together in a room and invite, broadly through the organization, your staff members to come and participate, and you think that they would have that kind of conversation, perhaps because they're already familiar with meeting with your C-suite and having conversations, then absolutely, by all means, do it like that. But if you're concerned that that might be a little bit intimidating and have a chilling effect on people coming forward, not because your C-suite is doing anything wrong, but just because this is new, and sometimes people will make up their own version of why this is being done. So you want to be sure that when you're putting out the word that you're inviting people, I would suggest that you say this is part of a VHHA challenge, and that you're excited to participate, and hospitals are doing this statewide, because it makes them less skeptical, I think, that there might be another agenda at work here. Because unfortunately, sometimes staff have other things that they're concerned about, and they fill in the blanks. So depending on what else is going on in the organization, that'll depend on how you structure it. If you've already got coffee with your CEO, some organizations do that, or there's a structure in place, or town hall meetings where you bring the senior leaders together and then you invite discussion with staff. If you've already got those systems in place, then you can take that existing process and structure and then adapt it to do this at one of your meetings. But if you've done nothing like this, I'd suggest that you start with a smaller, one leader or two leaders, and see how it goes, because you need to build that momentum and trust. Ultimately, you should be able to do it with whole big groups of people, but in a smaller group starting out, there may be less fear about being candid.
I would agree. Certainly smaller, more intimate, no more than two people. I find that, often when people want to share about an experience, there are two sides to that equation. Obviously they're really happy, and it was one of the most, it's one of the best experiences. They want to recognize a team. That's pretty easy to do, right? So the next step is to pull the team together and provide the recognition. But often, it's a basis of emotional kind of displeasure with the service, and they're emotional. And, I try to take that to a smaller setting and allow the emotion to separate from the more objective elements of what we can do better. And I find a smaller setting's the best to diffuse the emotion, and then ask the individual, how I'd love for other people to learn from this. And the best way for this to happen is to share this story. And how can I best share that story? And typically that person will guide you into, and you can offer some suggestions. But when in doubt, the smaller the group, the better, just to de-escalate the issue or emotion.
All right, so we are at time. That was a fantastic webinar, really. I just want to say thank you to Jonathan, Catherine, and Sentara Martha Jefferson for sharing their experience, to Carrie for, as always, providing expertise and knowledge to Virginia Hospital members. And this webinar is going to be posted to our website. It's going to be sent out to all Virginia Hospital executive teams and be shared with our board of directors as well. And so thank you all. Please follow up with me if you have additional questions, and have a fantastic Wednesday.
And Mike, can I just say one other thing?
Yeah, go ahead.
As this is being shared with all senior leaders, I just want to say one final thing. Do not underestimate the value of your attention. Even if you're not sure how this is going to go, even if it's something you haven't done before, doing this, taking the time, talking to your staff in this way, just setting it up and having that conversation has incredible value because they are paying attention. And so just trust that the value will come out of it, and that you spending, this time on it, setting this up, will have an impact in the organization. Because again, I know everyone is really busy. So, you've heard about the value that it's had at Sentara Martha Jefferson. It can have tremendous value, but even you just asking the question and being there and listening to the answer, it means something to your staff. It's important, and that's why they're saying in the forum to get leaders engaged. So we're really excited that leaders are engaging in this way with VHHA. So thank you.
Perfect. And Jonathan, any closing comments?
No, I think Carrie said it well. It's a leadership moment. That's what we're all here to provide. Our organization is, these moments of leadership and being engaged and being very introspective and cognitive around what we're here to do to take care of our patients and who we can learn from in that process is a team effort.
Perfect. All right. Well, thank you all very much. I really appreciate you taking the time out of your busy schedules to provide this content. I'll let everyone know when the webinar has been posted, the recording, and enjoy the rest of your day.
Thank you.
Thank you.